one of the reasons I like this presentation is that inappropriate sexual behavior is a common concern, whether in the developmental disability world, in the foster care system, and a lot in education, early childhood education. A lot of people jump to the idea that if a learner is exhibiting inappropriate sexual behavior, they must have been abused. And that's often not the case. And sometimes there are much simpler explanations. But within my sex education certification, um, I tend to do my continuing education through some of the sexual medicine organizations as opposed to the sex education, sex therapy organizations. And I was sitting at a conference several years ago and listening to medical providers talk about a bunch of different medical issues and their symptoms. And I thought to myself, well, those symptoms sound like a lot of the behaviors that people come to us with when they have a learner that they're concerned about. And so I took some time and put together this presentation. And so that's why this one is kind of fun for me. Okay. Maybe I can present, maybe I can move my screen. There we go. So our goals for today are to identify some hormonal effects on behavior, identify some medical issues with symptoms that include sexual behavior or things that look like sexual behavior, identify at least two preventative measures to those medical issues. But also, I just want to note that this presentation is for educational purposes and does not substitute for medical evaluation. I'm not that kind of doctor. So very often I do refer folks to pediatricians or urologists or gynecologists, etc. And I'm happy to help with referrals if those are needed, and I can help provide a resource. So let's just talk for a moment and about sexual development. A lot of times I see comments or hear comments about things like to the extent of he's in puberty. So folks have this idea that puberty is like an event that we go through or an event that happens to us, but it's not. It's a process that takes several years. There are changes in the brain that start as young as 6 for the girls and 8 for the boys. And I'm using gendered words here. I apologize for not being gender neutral. It ends up being very difficult at times to be adequately neutral when you're discussing medical terminology. So I do apologize in advance for that. The sex hormones, testosterone and estradiol, those start to increase somewhere between 9.5 and 13.5 for folks born male and 8 to 13 for folks born female. And then those hormones continue to increase until about mid-adolescence. So sexual maturity tends to be achieved, we're kind of like done with sexual development by about 17 for those learners born male and somewhere between 13 and 16 for those born female. Now, first periods tend to be somewhere around 12.5. This number has been decreasing through the years for a variety of reasons. The range is 10 to 15. Anything younger than 10 is considered precocious puberty. But what's interesting is that ovulation typically starts 2 to 3 years later than that first period. That said, the later that the individual starts their period, the closer in they're going to start ovulating, typically. So if you have someone who's maybe 14 or 15 when they get their first period, they might start ovulating pretty quickly after versus somebody who's 11. What's crucial about that, if you're working with folks with autism spectrum disorders or developmental disabilities where lots of extra training is needed for skill development, so for example, menstrual hygiene, those first few years of menstrual periods that are anovulatory, meaning occurring without ovulation, are unpredictable. So where some of us might rely on, our fabulous phone app to tell us, oh, wait, your period's due in 2 days, better start carrying supplies with you. Those folks who are not ovulating yet because they're early in their menstrual phase, their menstrual life, if you will. It's harder to predict. And so it becomes important at that point to teach them when they need a pad by looking at their underwear, but also to make sure that they have supplies on them at all times. Or, a lot more, I'm recommending the period underwear and just, they're expensive, but wear them all the time. So that there's not going to be a concern with, leaking through their clothes or whatever. I actually had a staff person the other day whose period started a couple days early, and as she came to me, she's like, "I'm wearing the wrong pants for this. I need to leave." And we do, I've got an office full of women, and we do keep supplies in the office, but she was like, "I need to not be wearing the pair of pants that I'm wearing right now." So, and it was just that, it started 2 days early, which can happen to those of us who do have regular cycles. So even more so with somebody who's not ovulating yet. So let's look a little bit at, all right, let's look a little bit more about these hormones. So increasing hormones early in life affect the brain and regulation of behavior and mood. This one is kind of interesting. So mood and self-esteem fluctuations occur with fluctuations in estrogen throughout the menstrual cycle. So if you look at my image on the bottom right, we've got that blue data set and the pink data set, and I'm trying to just move that. There we go. Okay, so the pink data set is estrogen, and the blue data set is testosterone. Um, uh, Individuals who have female hormones have three. We have estrogen, progesterone, and testosterone, and they all fluctuate throughout that 28-ish day cycle. So at this point, so what happens is we see this peak at about 24-ish, 25-ish, somewhere like that, and then it starts to decline from there. Same thing for progesterone and testosterone. This graph only has two of those data sets, but again, they start to increase somewhere around 8-ish. We see a peak around 24, 25, and then a gradual decline. And it's probably somewhere around this 46, 48 something mark that folks are starting to consider hormone replacement therapy. For those for those who have primarily male sex hormones, what we start to see is also testosterone declines with age. We see a peak somewhere around 20, and then as they say, it's all downhill from there. So men or those with primarily male hormones, we start to see the biggest drop off somewhere around 45, 50. With those who have female hormones, primarily, we talk about menopause, which is when menstrual cycles stop. Perimenopause is that pre-phase. But with those with primarily male hormones, we see what we call andropause. Now, at the peak of testosterone, we can often see increases in aggression or anger. So those of us working with, let's say, teenage and young adult males with developmental disabilities, autism spectrum disorders, et cetera, that's the time that we're most concerned about things like physical aggression. And where I live, there are a lot of clinics who won't take kids past like 13 because they don't want to deal with aggressive boys who are bigger than their female staff. And granted, it's a challenge, but that doesn't mean somebody doesn't have to do it, right? So what's cool about the mood and self-esteem fluctuations with the menstrual cycle is that at the mid-cycle, when estrogen is at its highest, mood and self-esteem also tend to be at their highest. So just as a little professional tip, if you want to ask your boss for a raise or you're going for a job interview, you should go when you are mid-cycle, when your estrogen is highest, because you will portray the best self-confidence. Don't go for job interviews when you're PMSing. Just sit home and eat your M&Ms. Now, declining hormone levels, again, so like that 50 and down, 50 years and up, right? When the hormones are decreasing. This is associated with increased risk of anxiety, depression, and mood instability. And so when you're talking with physicians, whether it's your gynecologist or primary care physician or whomever, urologist, whoever you're interacting with about hormone replacement therapies, one of the things they look at is the symptoms, not just for those with ovaries of things like hot flashes, but they're also looking at what is your mood doing? What is your anxiety like? And, just as a sort of disclosure, I'm 40, almost 49 years old. And several months ago, I did go have a conversation about that with my provider and said, like, hey, the panic attacks are getting really bad. We need to do something. And so like that was me, that was the point at which I started on a very low dose of hormone replacement therapy. And it just kind of bumps those hormones up just a little bit. So, if I'm, hanging out here, maybe it bumps me up just a smidge, maybe back to where I would have been at 46 instead of where I would now be at almost 49. Okay, so we're not taking somebody back all the way to where they were at 20 because that would not be healthy. I do know somebody who did that and it turned out very poorly. Um, but the idea is that we are mitigating the risk of depression, anxiety, and mood instability. We're also mitigating risks related to things like bone fractures and declining heart health, cardiovascular health, because these hormones, testosterone, estrogen, and progesterone, are needed for your bone health and for your cardiac health. And this is why people over 50 are more likely to break a hip or fall and break a bone than people in their 20s. Um, so these are all reasons to be in contact with primary care or whatever providers related to hormone health. But also when we're coming back and talking about folks with developmental disabilities, for example, let's look at or let's keep in mind that their hormones are going to have an effect on their mood and their behavior and their risk of depression and anxiety and mood instability, just like the rest of us. And so if we have a 50-year-old woman with a developmental disability who's suddenly, having behavior issues where she doesn't want to leave the house, let's consider the fact that maybe she's having some anxiety due to decreasing estrogen and progesterone in her system, and have that conversation with a primary care physician, as an example. Okay. Now, menstruation and abnormalities. So a typical menstrual cycle is right about 28 days and lasts about 4 days. Now, this is an average. So it could be that literally all of us in this room, none of us have this pattern. But this is just the average. We have an average of 28 days between periods and about 4 days of menstrual bleeding. Amenorrhea is the absence of menstruation. And so we can have primary amenorrhea or secondary amenorrhea. With primary amenorrhea, we have somebody who's reached the age of 15 and still has not had a first menstrual period. With secondary amenorrhea, we have somebody who was menstruating and has stopped without being pregnant or being in menopause. We also have situations with irregular periods, so not having those 28-day intervals. Now, even with people who have fairly regular periods, you still might go 27 days 1 month and 29 days another. When we're talking about irregular periods, we're talking about things like 24 days, 32 days, 28 days, 26 days, 21 days, 30 days as you're going through and logging your cycles. So those would be irregular periods. The biggest challenge to that for most people is if they're trying to conceive. Now, with our folks who have developmental disabilities, that can be difficult because, again, we might be trying to make sure that they have all the things that they need for adequate menstrual hygiene. It might be a little bit harder to manage if there is any kind of premenstrual behavior issues. And so that is sometimes an indication for hormonal intervention via like birth control to regulate those cycles. Another problem that can occur is long periods. So if somebody regularly has bleeding for more than 7 days, excessive bleeding, if somebody is regularly bleeding more than about 2 tablespoons worth. So what they usually tell you is if you're soaking through a pad or a tampon more than once an hour, that you need to seek medical attention. Irregular but frequent bleeding. So maybe somebody is bleeding for a day or two a couple times a month. That would be irregular but frequent bleeding. That can be indicative of hormone issues. That can be indicative of cysts, fibroids, endometriosis, sexually transmitted infections, etc. And then frequent periods are those that occur regularly, and I'm not going to say reliably, but regularly less than 21 days. So here's another image of the hormones in those who primarily have female hormones, and this is going across the 28-day cycle. So we have the follicular phase where all three hormones, estrogen, progesterone, and testosterone, are at low levels. And this is usually days 0 through about 8. And then right around day 8, estrogen picks up real high and peaks at around day 13. Progesterone takes a little bit of a bump, again, through about day 15 or so, and then testosterone is staying flat for a minute and just has a little blip somewhere between days 12 and 16. And then so day 14 would be when the person is ovulating. And so all three hormones are high at ovulation, and then they start to dip again. And we see with estrogen and progesterone, we see one more bump up in the luteal phase, very close to menstruation. Now, when estrogen is high, like I said before, we see better mood and self-esteem and things like that. So if you're working with an adult with a developmental disability who has some behavior issues around the menstrual cycle, you're least likely to see them here at mid-cycle. You're most likely to see them back here when all three hormones drop to their lower end. But one of the things that we see when progesterone is higher than estrogen, this is when folks get the munchies. This is when you want to sit home and eat your M&Ms. So progesterone drives the appetite a little bit. When estrogen is higher, we're more interested in mating, to be quite frank. So what you see if you're looking at like rats, for example, the rats will drop their calories low, like they'll forego meals in favor of mating at this point. But at this point, they're literally kicking the male rats out of their way to get to the food. That might resonate for some of you with your partners. I had a conversation about this once with some grad students at a conference, and they were cracking up and talking about how this related to their own lives. So just again, some things to think about. Sorry, when we're thinking about working with folks who this is their their primary hormone panel, and maybe we're seeing some problem behavior. One of my dissertation studies, we looked at working with a woman, she was 24, I believe, and engaged in some very, very high intensity aggression starting 3 days before her period. So right around day 25, when all three of them are starting to drop, and it would last through about day 27, 28. And I mean, she was 5'8" and over 200 pounds. So high intensity aggression in somebody that size is no joke. And we looked at her behavior across the month. We took lots of data. And what we found was if she had any aggression at this point in the month, it was more play with me, interact with me, I'm bored, I want attention. If she had aggression around here, what we were seeing was denial of access to her preferred foods. And so part of the intervention was telling parents to make sure that they always had a frozen pizza because that's what she wanted. But the other thing was we made air popped popcorn and some sliced fruit freely available to her during therapy time. And we saw between the two, we saw her physical aggression drop to 0 and maintain for 3 months. And then there was an insurance issue and we had to terminate services. But it did maintain for that duration at that point. And it was just a matter of a simple fix and really being able to understand how behavior is affected by hormones. All right, so another thing that I get often is some different sexual behavior issues, and one is what people like to come at with excessive masturbation. So any kind of excessive masturbation, I start to ask a lot of questions. Is the person masturbating to completion? Are they having an orgasm, ejaculating, etc.? It's more often folks with with male genitalia than female genitalia, but I do see both. So let's look at some of the medical things that might contribute. So one thing is pinworm, and you're more likely to see this and diaper rash in folks who are not toilet trained. You can see pinworm in folks who are toilet trained. You're just more likely to see it in the younger ones, but they might be uncomfortable if like they literally have worms around their genitalia, right? Diaper rash, again, those who are not toilet trained, they could have discomfort due to, being wet, being dirty, etc. Allergies to detergents. So, if underwear is being washed in a detergent that the person is allergic to, it can be causing irritation, and the person might be itching, burning, scratching at their crotch because the detergent is irritating their genitals. In general, clothing that is too tight, underwear especially that is too tight, um, can cause issues because the person is trying to adjust so that they're not uncomfortable, right? So we want to always recommend loose fitting, breathable underwear. So underwear should be cotton, or some other comfortable, breathable material, maybe a moisture wicking material if the person is very active or tends to get very warm. But satin undies are cute, but they're really not good for you. There's something called persistent genital arousal disorder. And it's precisely what it sounds like. The individual has persistent genital arousal. So the folks with penises might have erections for 8 or more hours per day, no matter how many times they masturbate to orgasm and ejaculation. The folks with vulvas, uh, they mention like a persistent arousal sensation in the clitoris, like a persistent, like almost like a thumping sensation in the clitoris. Um, so the the folks with penises, this is a little bit more concerning if, from a social standpoint, if somebody's trying to maintain a job, for example, you can't as easily, go out into the world with an erection all the time. Though both people with male and female genitalia comment that this is debilitating, and there's actually a fairly high suicide rate in folks with PGAD. There are some phenomenal physicians, thankfully increasing in numbers, who are doing some really great treatment and continuing research on PGAD. Some in the US, some in the UK. I've seen some of my colleagues just do some phenomenal collaborative work around this. There is one physician in particular, Dr. Irwin Goldstein. He's in San Diego. His practice offers a free 15-minute-ish consultation to help determine if what the person is experiencing might be PGAD, and then either you can go out to San Diego to his clinic, or I believe that they'll help you find alternatives. I'm finding more and more people, still not a lot, like probably like a handful total in the country that I've found, who are skilled at treating persistent genital arousal disorder, but I've definitely referred, I would say, 3 in the last year or two to Dr. Goldstein for that free assessment, just because I'm seeing the red flags. And what I'm usually seeing with the red flags is a young, prepubescent kid who is engaging in behavior that seems like masturbation to the exclusion of even preferred activities. So this is a kid who won't take the tablet, they won't take snacks, they won't go play with their favorite toys. They are just engaging in something that looks like masturbation. Um, with the with the little ones who have penises, it's a little bit easier to see if they have an erection. You obviously can't assess quite as well with somebody who has a vulva, but the clue for me often is, or most often is, somebody who, like I said, is foregoing preferred activities, preferred foods, things like that, in favor of engaging in this kind of masturbatory behavior. The last one I'm going to point out here is actually a medical emergency. It's testicular torsion. And that's the image that I have up here on, excuse me, on the screen. It's when the um, the vessels leading to the testicle get twisted, torsion, right? Twisting, and it cuts off the blood supply. So if this requires emergency surgery, if this is not remedied, the person will lose that testicle. Sometimes it's evident that it's discolored. Sometimes it is not evident that it's discolored. Sometimes you'll get this bit of swelling because the blood is engorging the testicle. If you pick up on something like this is an emergency room visit. But also the person is very uncomfortable. The testicle is having, they have pain in the testicle, but also abdominal pain is very common. We had one client, I don't know, probably 8-ish years ago, who ended up with a testicular torsion. And at first, mom was downplaying it because he was saying, "Oh, my belly hurts," but they were like doing some non-preferred activities at home. And then he kind of like doubled over in pain and was grabbing at his testicles. And mom was like, "Hey, wait a second, something's wrong here," and took him to the ER. And he had surgery like within an hour of getting into the into the hospital. Some other sexual behavior issues. Now, other things that require medical assessment, rashes of the genitals, any kind of discharge from the genitals, any kind of pain or burning. Oh, sorry, I have discharge here twice. I apologize. Genital bleeding, that's not menstrual bleeding. These require medical assessment. However, let's look at some of these common causes. So I mentioned before allergies to detergents, could be soaps, could be bubble baths. We had a little girl here about a year and a half ago. No, it was about, I think it was last Christmas time. Her grandparents bought her these like really cute bath bombs, and she had a terrible reaction to them and ended up with extremely like red, angry inflammation on her vulva. And this poor little girl, who was mostly non-vocal, and therefore couldn't articulate what was going on. She wouldn't sit. She kept trying to take off her pants and underwear. You could see that she was trying so hard not to urinate. Um, and I finally said to mom that, one of my female staff happened to have been kind of keeping a half an eye on her in the bathroom because we were trying to figure out what was going on, and noticed how red and inflamed she was. I said, "Please take her to the pediatrician. Like, I think she's got some inflammation there going on that needs to be treated." And sure enough, it was like the oatmeal baths and some steroid creams and things like that to calm it down. And it was caused by a bath bomb that grandparents bought her for Christmas, which was so sad because this was like the ultimate girly girl and she was all about those bath bombs. But we helped parents find, and then grandparents find some bath bombs that were more, they didn't have colors and smells and things like that, and she could still enjoy them. So soaps, bubble baths, detergents, clothing fabric can even cause issues. My daughter is she's medically fragile, and we have to bring our own linens with us to hospitals because she's had anaphylactic reactions to hospital linens. And it's really the detergent that they're washing the hospital linens in, but she has had reactions to specific fabrics as well. Hygiene products, whether it's menstrual hygiene products or just cleansing products, those can cause allergies. Poor hygiene can cause problems, can cause infections, can cause irritation. Condoms, people can be allergic to condoms. If you have a latex allergy, you need to make sure that you're using non-latex condoms during your interactions. But the lubricants can cause issues on the condoms. Sometimes it can be very difficult to find products that somebody doesn't react to if they're highly sensitive. Likewise, spermicides can cause issues, as can enhancers like the KY Yours and Mine that causes like the warming sensation. Any of those have ingredients in them that somebody can be allergic to. And then tight clothing can also cause discomfort. Now, um, another medical issue, something called bacterial vaginosis. So with this one, we see symptoms of discharge plus odor and pain. The discharge usually has a foul smell. And this can be usually is caused by something entering the vagina. It could be caused by poor hygiene, such as wiping incorrectly. It could be caused by sexual interactions. It could be caused by swimming in a non-clean pool. Um, One of my kids ended up with it after lifeguarding in open water on our local river. And she told me after the fact that her female coworkers told her that even when they don't have their periods, they wear a tampon when they're lifeguarding so that nothing goes up. And that's how they were preventing bacterial vaginosis. Um, about yeah, sorry. That's how they were addressing or preventing rather the bacterial vaginosis if they had to jump into the river as a lifeguard. Urinary tract infections, if you've ever had one, you know that they're not pleasant. But again, if you've got somebody, especially with an intellectual or developmental disability, you might see urinary accidents. You might see holding themselves at their crotch or where they would urinate from. A lot of folks, I don't know why a lot of folks jump to sexual abuse when somebody is suddenly having urinary accidents. I first think, let's get a urinalysis on them and see if they've got a UTI. Psoriasis and eczema, if somebody has a history of those and they affect other parts of the body, they can certainly affect the genitals as well. There are other dermatology issues. There's something called lichen sclerosis. And this one is actually very often mistaken for sexual trauma in young children. Because of the adhesions that it causes. Also, certain precancerous lesions can cause discomfort as well as genital bleeding or discharge. Infections such as sexually transmitted infections, yeast infections, and vaginitis can cause discharge, pain, burning, genital bleeding. And then the obvious that people jump to first, which again, I don't think they should jump to first, is the sexual abuse and trauma can cause many of these symptoms. Um, my point in this one is, if we have somebody who is scratching at their crotch, I have one of my young adult women here who this is a frequent behavior issue with her, but she has very, very bad allergies. She has a history of UTIs. She has something called interstitial cystitis, and that causes discomfort as well. Um, so when she's grabbing at her crotch, we usually make sure mom is aware, and it usually means she needs a urinalysis done to make sure she doesn't have a UTI. We've also been working with her on the fact that this is not socially appropriate and you can't do this in public, and you need to go to the bathroom if you need to adjust your underwear or rub yourself because you're uncomfortable or whatever it is. Um, that's different from folks who, maybe are masturbating in a public place, right? She's not masturbating, she's relieving discomfort. So we need to make that distinction and really be detectives to figure out what is going on with that individual in that situation. So the other thing I like to look at is medications involved in sexual behavior. So there are a lot of medications that interfere with sexual response, and we always want to check side effects. So one of my most common Google searches is sexual side effects and then the name of a medication. If you just search the term sexual side effects, you get a punk rock band because there is a punk rock band by that name. But the if you search the term sexual side effects, Zoloft, you're going to get these sexual side effects for Zoloft. So one of the things I do whenever one of my learners is on a new medication is I do check a side effect profile so that we know what to look for, but I specifically look to see if there are sexual behaviors or sexual side effects that might be related that we also need to watch out for. Likewise, when I get a consultation request for some sort of sexual behavior issue, I ask about medications because I want to see, is this person on a medication that could be affecting their sexual behavior? I also want to know, are they on a medication related to something else that could mimic sexual behavior? So as an example, I had a phone call several years ago from a colleague. The individual was a male, IQ in the 30s or 40s, as I recall, non-vocal verbal. And he was, to use the staff terminology, he was humping the kitchen floor. And what's interesting is that it was only the kitchen floor. And so I said so my friend Mitch, Dr. Mitchell Tepper, who specializes in sexuality and spinal cord injury. He said, I know what you're going to ask me. I forgot to ask. I'll get you an answer and call you back. And I said, well, what am I going to ask, Mitch? He goes, you're going to ask me what medications they're on. I said, good call. So he called me back about 30 minutes later, and this poor guy was on seven, yes, seven different forms of laxatives and stool softeners. And I said, he doesn't have a sexual behavior problem. He's impacted. Please take him to the emergency room. And that was exactly it. And part of my clue was the fact that it was the kitchen floor. The rest of the house had carpet. You're not going to get the same pressure and counter pressure on carpet as you will on a hard floor. And so he was getting pressure into his abdomen to help relieve the pain from the impaction. Clearly, all those laxatives and stool softeners were not working, but the behavior went away. And so they didn't need my intervention anymore. They probably just needed a gastroenterologist. So that's an example, again, of where a behavior might look sexual, but not be sexual, and why we need to do some detective work before just implementing an intervention or making an assumption about what's going on. So now let's dig into some medications that can cause sexual behavior issues. So antipsychotics, your Zyprexa, your Geodon, your Haldol, your Abilify, these cause decreased libido. They can cause arousal or erectile dysfunction, delayed ejaculation, but also something called priapism. With priapism, you have somebody with a penis who has about like a 70% erection all the time. And so that needs to be um, addressed, because that can certainly contribute to somebody touching themselves more or attempting to masturbate more. All of the antidepressants, all categories of antidepressants, so your SSRIs, your SNRIs, not as much the tricyclic antidepressants and not as much the MAOI inhibitors, but definitely the serotonin and norepinephrine related ones cause reduced desire, erectile dysfunction, decreased lubrication, which can be an issue, especially if you have a woman who's a little bit older and she's already having decreased lubrication. There might be some burning related to that, burning and dryness, as well as delayed orgasm or absence of orgasm. So you might have somebody who's trying to achieve an orgasm for a longer period of time because they're not successful. And so you might have something that looks like excessive masturbation. Your anxiolytics, all of shoot, the word just dropped out of my head. But your Xanax kind of medications, not as much your Buspar kind of medications, but your anxiolytics can cause some sexual dysfunction in folks with vulvas, less so in folks with penises. Cardiovascular meds. Oh, what about those, right? Well, most doctors, urologists especially, will tell you that the best indicator of good cardiovascular health is the functionality of somebody's erections. So if somebody is having good erections, that means they have good blood flow, and they probably have decent cardiovascular health. So when we see somebody with cardiovascular medications, such as the meds for high blood pressure, we more often see erectile dysfunction because they don't have good blood flow. We also often see delayed orgasm or absence of orgasm. So again, you might have somebody who's trying a little bit harder. Endocrine meds. So folks could be on endocrine meds for a variety of reasons. Prostate cancer is one, breast cancer, GYN cancers, also thyroid issues. These can cause erectile dysfunction. The contraceptives have mixed results. Some increase libido, some decrease libido. Some of it is actually a mind thing, if you will. When a woman knows she can't get pregnant, sometimes she's a little bit friskier, shall we say, especially if she's not wanting a child. The antiestrogens, such as those used for breast and gynecological cancers, very often cause dryness. The dryness alone can cause pain, but they can also cause pain just on their own. And then stimulants. So those fun ADHD meds that lots of our folks take, those can cause reduced libido. They can also cause delayed arousal. So This is not as much of an issue for many of our younger learners with developmental disabilities, but perhaps somebody has a partner who takes ADHD medication and they're having some sexual dysfunction. Usually, if they take the ADHD meds in the morning, they're okay by the evening. But there may need to be adjustments to dosing or medication timing to address that issue. But I think, this is just, a summary but I think, we're, especially if you're working with young adults or adults with developmental disabilities, we are seeing a lot more antipsychotics, antidepressants, and anxiety meds. And then we're starting to, as they continue to get older, to see those blood pressure and other cardiovascular meds. So how do we prevent all of this? Well, again, the loose underwear. If you're using lubricants, using a water-based, sugar-free lubricant, I gave some examples here of Sliquid and Good Clean Love. Good Clean Love you can get at Walmart and Target nowadays. When it first came out, you had to order it from the company. And I had like a box of samples at my house, which was kind of cool because they gave them to me at a conference. Avoiding soaps with perfumes and dyes. Even things like essential oils, just because they're natural doesn't mean they're safe. Um, avoiding things that have smells and colors. Using natural, organic, fragrance-free, unbleached cotton feminine hygiene products. I have some examples on the next page. The first one that really was on the market was Seventh Generation. But there are other brands now that you can, again, find at Target very easily. Lola, L is Love, The Honest Company, Honey Pot. Maintaining good cardiovascular health, because again, those cardiovascular meds can affect sexual function. Using hypoallergenic, fragrance-free laundry detergents. I mean, again, we all like to smell good. We like our clothes to smell good, but not at the risk of irritating our genitalia because our underwear has chemicals on it. Avoid prolonged sitting on hard surfaces, which can also exacerbate discomfort, which can lead to touching oneself or needing to adjust underwear and pants more often. So here are just some more of those examples. So L is a company. I just literally took pictures at Target one day when I was picking something up. So we've got L is one company that has organic cotton tampons. Cora is another brand. Tampax has a pure and clean version. Um, and Always now has a pure and clean version. Again, Seventh Generation is still an option. And these are just some companies. Like I said, The Honest Company has stuff, Honey Pot has stuff. Target, in my experience, at least in where I live, has better options than Walmart, but also there's Amazon, right? If Amazon doesn't have it, you don't need it. Here are a couple of helpful books that I find useful in my practice. The ABCs of Sexual Health by Kevon Wiley. I did cite this book in the presentation. The Guide to Getting It On by Paul Ioannidis. Paul is one of my favorite people. He's just completely unhinged and hilarious, but also brilliant. He's got a doctorate in psychology. He's an old-time psychoanalyst, but he's an outstanding sex therapist and really understands human sexuality in such a unique way. But his book is just hilarious. It's 972 pages long, and it covers just about everything you can think of. But I want to say it's 972 pages of light reading and broken up into some really good chapters.